Good afternoon, everyone. At the outset, I must compliment Dr. Pelajani, Dr. Satyavan Sharma, Milind, for having charted out a wonderful topics for the meeting. Well, I'm also a little worried because on my back I have the monkey on me to finish within the time limits. But also, as Milind has said, that this particular session is being sponsored by Novartis. So I think I have a leverage of exceeding, if at all needed, because Inclisiran is the drug which is being manufactured and marketed by Novartis. So friends, my job has been done much easier by the previous speakers who talked about what are the benefits as far as lipid lowering is concerned. And we as cardiologists and physicians over the years know how beneficial it is to reduce the LDL levels to the determined guidelines as per the risk factors, those who have only risk factors or those who have risk factors plus established atherosclerotic cardiovascular disease. As we know, atherosclerotic cardiovascular disease is a leading cause of cardiovascular morbidity and mortality. And it is not surprising that in over a minute, almost about 34 patients or people die with atherosclerosis worldwide, either of myocardial infarction or stroke. And also it is important to note that as per the Da Vinci study, that among patients who have got risk-based goals of LDL levels, only 33% achieve that particular goal. And in patients who have established atherosclerotic cardiovascular disease, only about 18% achieve that particular recommended levels of LDL. And this could be basically because of lack of the familiarity as far as the healthcare physician is concerned with the guidelines, or it could be the high cost of medications. It could be because of patient reluctance to be treated with high intensity lipid lowering therapy, or it could be concerns as far as the statin related adverse events are concerned. Previous speakers have highlighted also that for each millimole per liter reduction in LDL, it reduces the relative risk of atherosclerotic cardiovascular disease or events by almost about 10% during the first year, about 16% in the second year, and almost about 20% in the ensuing 3 years onwards. Now, Inclisiran is the first and the only LDL-C lowering small interfering RNA therapy that selectively targets the liver. And how does it do? It does by preventing the production of target protein PCSK9. So Inclisiran increases the hepatic uptake of the circulating LDL-C, thereby reducing the LDL-C levels in the bloodstream. Inclisiran mimics the body's natural process of RNA interference to selectively target the PCSK production. So it reduces the production of PCSK, and that is how it acts. It has got two strands, the passenger strand, which is attached to the GalNAc, which allows for targeted delivery of the Inclisiran only to the liver, and the guide strand, which targets the MNRA, which by complementing base pairing and allows only for targeted degradation. The mode of action is basically in the liver, and Inclisiran is a long-acting synthetic small interfering RNA directed against the PCSK9, conjugated to the GalNAc, which binds to liver-expressed ASGP, which is the Asialogo glycoprotein receptors, leading to rapid uptake of Inclisiran specifically into the hepatocytes. With less PCSK available, more LDL receptors, as Samir has already shown in his slide, more LDL-C receptors can be recycled to the hepatic membrane for the LDL-C uptake and thereby reducing the level in the bloodstream. Almost around 100 to 200 RNA-induced silencing complexes per cell can effectively suppress the gene expression, thereby enabling dosing to the patients to be months apart. The GalNAc-mediated liver specifically allows for use of lower cumulative dose, thus enabling subcutaneous administration of this particular drug. As far as the pharmacokinetics are concerned, in the plasma, the peak plasma concentration occurs in about 4 hours and a plateau in about 12 hours. The plasma concentration rapidly decreases within 24 hours, and it is 87% protein bound. As far as the liver is concerned, as I said, ASGPR uptake is within 8 hours of administration. Inclisiran prevents translation of PCSK9, mRNA through RNA interference. That means it acts on the mRNA to the production of PCSK9. There is no effect on the major cytochrome P450, that is the CYP450. Thereby, it is not expected to cause drug-to-drug interactions or to be affected by inhibitors or inducers of CYP450 enzymes. The chances of interaction as far as drug is concerned is very, very minimal as far as inclisiran is concerned. Kidney is the main organ of inclisiran elimination. The doses and administration, it gets as a pre-filled syringes. It is about 1.5 ml per syringe. It has 300, to be very precise, it is 284 milligrams of inclisiran. It is given by subcutaneous injection in the abdomen by the healthcare professional. The initial 2 doses are 3 months apart, and after that, it is every 6 months for ensuing years to come. As far as the pharmacokinetic properties of inclisiran is concerned, there is no drug interaction expected. Co-administration with atorvastatin or rosuvastatin not associated with exacerbated toxicities, no dose-limiting toxicities, no genotoxicity or carcinogenic, no off-target effects observed, no effect on fertility or embryonic development, no dose adjustment is necessary for patients with renal or hepatic involvement. The only adverse event is related to the injection site problems, which is pain, erythema, or rash, seen in about 5% of the patients. Now, inclisiran demonstrated effective and sustained reduction of LDL. The effective reduction was almost close to about 52%, and the sustained reduction was close to about 53%. Not only that, it reduces the total cholesterol by close to about 30%, non-HDL cholesterol by about 40%, and the ApoB lipoprotein reduction is close to about 40%. Beyond that, it has got some additional actions also. It reduces the triglycerides by close to about 13%, the Lp(a) by about 20%, and it increases the HDL-C by about 7 to 8%. Now, as far as the long-term efficacy is concerned, by the Orion 8 trial, they found that almost close to 80% of the patients achieved their pre-specified LDL-C targets. 90% patients achieved that global lipid target at any visit, and on an average, there was 50% reduction in the LDL levels at subsequent visits. As far as the side effects and the safety is concerned, there are practically negligible side effects except for the injection site side effects, as I said, in about 5%, giving rise to rash and pain. But as far as hepatic events, worsening of the diabetes or MACE is concerned, practically no side effects. Also, when inclisiran was tested in Asian patients with atherosclerotic cardiovascular disease or high risk for atherosclerotic cardiovascular disease, they found that the ratio of Lp(a) to baseline levels was approximately 41% lower than placebo at the end of 1 year. So it significantly reduces the Lp(a) in Asian patients. And these are one of a few of the comprehensive clinical trials which have gone. The phase 1 are already over. The phase 2 also are already over. Extensive trials, of which phase 3, there are some, the Orion 4, the Orion 8, the Victorian Prevent, the Victorian Prevent 2, and the Victorian Plaque are still ongoing. And they'll give us the data as far as the effectivity in preventing cardiovascular disease is concerned. As I've already told you about the effectivity of inclisiran in the liver, that it can be given, and inclisiran leads to sustained decrease in the protein production in the liver, and hence it can be given only twice a year as a dose to reduce the LDL cholesterol. What about the benefits as far as the existing therapy is concerned? As you know, statin are to be given every day. PCSK9 inhibitor has to be given every 15 days, and both these can reduce the LDL levels by about 20 to 50% and has got GI intolerance, sometimes myopathy. But as far as inclisiran is concerned, it has to be given every 6 months, and it reduces the LDL level by about 45 to 50% on top of statins, and there are only injection site problems which occur in about 5% of the patients. This is just highlighting that in cases of ACS or in patients who are established atherosclerotic cardiovascular disease and who are at a very high risk, it is important to see that the LDL levels are brought close to or less than 55. And that can be achieved, if not possible, with the highest level of rosuvastatin plus ezetimibe, or if you add an bempedoic acid also. If not, then you add on to the PCSK inhibitor or you add on to inclisiran. And this is also recommended through the ACC as well as the NICE guideline of 2020. And this is the latest recommendation, just to highlight that if you have a calcium, coronary artery calcium score, and if it is significantly high, now they recommend that the LDL levels are brought down to less than 50 and close to 30, particularly in patients who have got established atherosclerotic cardiovascular disease, if they have associated diabetes, and if they have recurrent coronary artery problems, to reduce the LDL levels to less than 30. So what does inclisiran data mean to us? It gives twice yearly maintenance doses, effective and sustained LDL reduction, ability to achieve the LDL targets as per the 2023 ESA and the ESA guidelines, and a well-tolerated safety profile. Yeah, so thank you very much.